Hello everyone, myself Dr. Himani Prajapati and I am Assistant Professor at LG Institute of Physiotherapy. So let's talk about neurological bladder. I'm not going in detail about the anatomy part of the bladder, but starting with the introduction, it is a it can be because of urinary tract dysfunction. Condition may be congenital or acquired. It has no cure, but it can be managed. Most cases managed with medication and intermittent catheterization. Causes: it can be because of spinal cord injury, diabetes mellitus, heavy metal poisoning, acute infections, spinal cord tumors, syphilis, and benign prostatic hyperplasia. This is the just an overview that which are the areas are involved if it is a cause. See here, starting with the tabes dorsalis. The DRG group of neurons are mostly affected in tabes dorsalis. If it is a multiple sclerosis, then this white matter that are the tracks controlling the micturition is responsible. If it is a diabetic neuropathy, then the peripheral nerve is involved. If it is a drugs, then it has a direct impact on the urinary bladder. If it is a spinal cord tumor, this tumor, if it is located in the sacral region from S2 to S4, then there can be a dysfunction in the urinary bladder or the urinary tract. If it is a poliomyelitis, then AHC group of neurons are affected. If it is a cystitis, then also the inner part of the bladder is inflamed, and that can be the reason. If it is a vesicle calculus, means if it is a vesicle stone or something like that, then the output part of the urinary bladder is responsible, because this stone is getting detached from the bladder and it will obstruct the flow of the urine into the urethra. If it is a benign prostatic hypertrophy, so here is the prostate, and if it is get hypertrophic, then it will compress the urethra and it will obstruct the flow of urine. And the last is the urethral stricture, means the urethra get abnormally constricted, then it can be the cause, right? So this is just an causes and where can be the location and how which in which disease where is the involvement of the whole tract that is showing in this picture. Other causes can be, if it is a non-neurological, then it can be a stress, that is a weakness of pelvic floor muscles. Reasons can be injury from childbirth or decreased function because improper use when coughing, lifting, breathing, straining with constipation or fecal impaction. Bladder dysfunction. It can be a urge, it can be a retention, or it can be a overflow. So these are the possible reason you can go through it for the bladder dysfunction. That is a first for the urge, it is a detrusal instability, sudden urge to go to the bathroom with or without loss of urine. Possible reasons can be infection, prolapse of vagina, cystocele, weakness of the pelvic floor. If it is a retention, then inadequate emptying of bladder, or it can be associated with the pressure or pain in the lower abdomen. Overflow, overextension of the bladder, and it is empty by constant dribbling of urine when the capacity is exceeded. That is the overflow incontinence, right? Now we will go to the other causes like psychogenic. That is a non-neurogenic bladder. In that, the Hinman syndrome, hysteria, schizophrenia, or depression can be the possible cause. If it is an endocrine, then diabetes and hypothyroidism. Hormonal deficiency, in that it can be lack of estrogen. Inflammatory, in that cystitis, vulvovaginitis, or prostatitis. Obstructive, tumor or prolapse. Pharmacological, means medication for treatment of hypertension or depression. Hypertension are hypertensive drugs, in that mostly it can be lead to diuretic drugs, so it will lead to in a constant diuresis will lead to problem in the urinary bladder also. Possible symptoms can be retention, frequency, urgency, and stress incontinence. Now, types of neurogenic bladder. There are three types. That is upper motor neuron type of bladder. That is a failure to store urine because the bladder it is in the spastic state. Lower motor neuron bladder means failure to void. That is the muscles are hypotonic, so it will fail to void. And third is uninhibited bladder. This is the just a picture demonstrating the control of the micturition reflex we have already studied in the first year. UMN bladder. It is also known as spastic bladder, automatic bladder, or the reflex bladder. When the lesion is in the spinal cord above the level of micturition reflex center, that is S2 to S3, then it is known as UMN type of bladder, and in that reflex arc will be intact. Injury above the sacral micturition center will lead to reduced capacity, reduced involuntary reduced capacity will lead to involuntary detrusor contraction, lead to high intravesical pressure, marked hypertrophy of bladder, spasticity of the pelvic striated muscle, and failure to store the urine. Always remember that pelvic muscles are the striated muscle, and that's why the reason that spasticity will develop in these muscles also. Now, signs and symptoms are frequent involuntary urination. Small capacity means that is less than 300 ml to store the urine. Scanty amount associated with the spasticity of the lower extremities. Lack of bladder sensation. Upper tract dilatation, that is reflex or obstruction. Voiding may be triggered by stimulation of perineum or genital. So here we are using the principle of associated reaction. So voiding can be triggered by stimulation of the skin because the muscles are in the hypertonic state. And last will be the urinary infection. LMN bladder. It is also known as placid bladder, atonic bladder, and the autonomous bladder. When the lesion is below the micturition center or it completes to destroy at the level of S2 to S4, then it will be element type of bladder. Lesion is in the cauda equina or the sacral parts. Now these are the injury at or below the micturition center, means large capacity of the urinary bladder, low pressure, no voluntary contraction, decreased tone of external sphincter, failure to evacuation, and evacuation may be accomplished by straining of the lower abdomen, that is Valsalva maneuver. Signs and symptoms will be overflow incontinence, that is dribbling of urine, when the bladder will fill up to certain level of filling pressure. After that, the bladder will start to overflow, and that will be seen as a dribbling of urine. Reduced sphincter tone, that is external sphincter tone, sensory loss in the perianal area, and the element size in the lower limbs, means hypotonia and everything. Here is the difference between the LMN and the UMN type of bladder. As I have previously mentioned, that lesion at the corners or the cauda, and lesion above the corners or cauda. Here the same center, see, this is very important part, that if it is involving the T12 vertebral injury or below, then it will be LMN, and if it is involving T12 injury or above, then it is in UMN, because at T12 level there comes the lower part of the lumbar to sacral region. So here there can be a chances of damage of the sacral roots, right? Here are the signs and symptoms that we have already discussed about this. Now coming to the uninhibited bladder, that is a hyperactive neurogenic bladder. The lesion will be in the midbrain, causes a continuous excitation of the spinal micturition centers, resulting in infrequent and uncontrollable micturition. The Barrington's nucleus in the brainstem is a center for micturition. It is the urinary bladder with frequent and uncontrollable micturition and continuous dribbling of urine. So this is a very tricky if we come across such patient. So we have to look for all the signs and symptoms, and if it is a mixed kind of signs and symptoms, then we can consider it as an uninhibited bladder. Urge incontinence. There means there are the three types of incontinence. First will be the urge incontinence. So in urge incontinence, it is an involuntary loss of urine associated with a strong desire to void. In that there are two types. First will be the sensory urgency, which is related to the infection, urinary calculi, or the bladder tumor. Second will be the motor urgency, and that it is due to the detrusor muscle instability, and it is mostly seen in the elderly group of patients. Second is the genuine stress incontinence. It is a voluntary small leak of urine occurring when the intra-abdominal pressure is raised. If a high intra-abdominal pressure exceeds the urinal pressure, the outlet mechanism will become incompetent and the urine will be voided. Right? So here are the references, that is a Snell's Clinical Anatomy, Sullivan, Darcy, and I took some from the Google. I hope you all understand, and thank you.